I've been in a structural integration training program, aka Rolfing, and can't help but notice that some prominent PTs seem to hate any method of manual myofascial release, or which seems to have an effect on the myofascial matrices and ease of movement in portions of the body. Why is this? Clearly, people do improve for manual therapy, and while it is not the only answer and can be better or worse, it seems to be wholly discredited as pseudoscience, implying merely a placebo effect. But shouldn't there be credence to case studies instead of picking and choosing studies with the intent to discredit contrasting strategies? To be frank, it seems like unnecessary bullying as each professional seems to have a tendency to smack talk the other modalities. In short, do you think manual therapy, increasing fascial glide, is useless or inefficient, or that there may be a synergy between manual therapy and coached movement? Thank you for what you do. Well, Bryce, I feel your pain. And the reason why I say that is because I think the polarity of any topic, of any modality that we incorporate as movement professionals is just par for the course nowadays. It seems like polarity and not having any nuanced opinion is more the norm now than the exception for a multitude of reasons. And that transcends movement. I mean, that's just the day and age that we live in. So I feel you. We can definitely say that manual therapy has some efficacy, and I think the people that completely throw it out as pseudoscience is throwing out the baby with the bathwater. And the reason why is because there's a lot of conditions that have shown in the research utility for manual therapy. I'll link these in the show notes, of course, which will be found on zachcouples.com/manual-therapy, which I would highly encourage you to check out because I write blogs that go along with this. So give it a shot. There's a study I got pulled up right now. Ooh, this one's a hot one too. And I remember when I was back in the Chicago suburbs, one of my colleagues, she was going through a residency through Evidence in Motion. And she told me of this study, and I got it pulled up right here. It's called Manual Therapy for Osteoarthritis of the Hip or Knee, a Systematic Review. And she reviewed this. I checked it out as well. And it's not a big study or a big review. They have like 280 total subjects. But get this, here's one thing. This is in the abstract. There is silver level evidence that manual therapy is more effective than exercise for those with hip OA in the short and long term. So we already have one study showing manual therapy greater than exercise, which that's if you're an exercise, and I'm like nuts about exercise. I get juiced up as all hell about movement. In fact, like my bias is I want to get people moving and grooving first and foremost before I get all touchy. But there's a systematic review, highest level of evidence, indicating that manual therapy may be more effective for hip OA than exercise. That's where you got to check your ego at the door with this stuff. There's a lot of research out there for manipulation as well, in terms of things like cervical radiculopathy. I'm actually going to be taking a manip course through the Spinal Manipulation Institute in a couple weeks and just reading some of their research there. You can find research to support utilizing manual therapy for a wide variety of interventions. I'll give credit to Spinal Manipulation Institute. When I took their dry needling courses, they put out a ton of evidence showing that something such as dry needling can be effective for a variety of conditions. And now, of course, you also have to consider that there's going to be some bias in that research, which there's bias in everything that we have. But what I appreciated about them as well in particular is when I took their extremity course, they were very adamant about the low amount of evidence that was out there for that particular modality. So you can find evidence for and against. And I think the crux of all this stuff in regards to, well, really any intervention that we have as movement professionals, whether it's manual or exercise, we don't have anything that's concrete. You can't be doing, eccentric Achilles tendon exercises and the Epley maneuver for everyone and the Lockman's test. Like, those are probably the only things that have a fair amount of evidence. So we don't have anything that we can operate in that's conclusive to say that it's effective or not. And there's plenty of research out there showing manual therapy has a place for a lot of different conditions. You have to check it out. And also realize that it's not the highest level of evidence, but really in our profession, we don't have anything that is at the highest level of evidence. So I think a lot of these people, for whatever reason, and I don't want to, there's names out there. I don't want to name names. I don't want to speak on anyone's behalf because I don't know where they're coming from and I don't know their population. There was a post that my dear friend, mentor, Daddy O'Pops, Bill Hartman, put out that people who have expert level clinical reasoning don't throw things out. They ask first, when would this be useful? When would this intervention be useful? And I think the same thing applies here in manual therapy. When would manual therapy be useful? Now, there's a few different things that Bryce talked about in this. Is it merely placebo effect? I don't think we can say that that's the case. There's a couple good articles. I can't remember the author, but I will link them in the show notes, showing a lot of neurophysiological changes when it comes to manual therapy. There's some interesting osteopathic literature out there, also indicating that there's some changes that you can see in the viscoelastic properties of tissues with manual therapy intervention. For those of you who don't know what viscoelastic properties are, think of our tissues within our body as silly putty. Because silly putty is viscoelastic, so you can create a lot of tension with it, you can pull it slowly, and it can stretch. Our tissues are adaptable. Manual therapy has been shown to improve those things. So there are things beyond the placebo effect when it comes to manual therapy. And really, I hate the term placebo effect because that implies that this works because it's fake. And that's not what the placebo effect is at all. Placebo effect is probably better said as non-specific effects. And by non-specific effects, that means we don't know all of the effects when we're performing an intervention. And that's because with research, there's a limitation in the amount of things that we measure. Most researchers have a particular hypothesis in mind, and then they go and measure things to either prove or disprove that hypothesis. For example, when you went back in the day to some of the research on transverse abdominis activity with or without low back pain. Well, people only would do EMG research of the transversus abdominis. And you remember the classic study by, why can't I think of his name, Paul Hodges, where raise the arm and the first muscle that activated was the transversus abdominis. And that was the first muscle that changed its timing when someone had low back pain. Well, there's several other tissues that we didn't measure within those studies. How do we know that it wasn't the soleus that was the first thing that activated? How do we know it wasn't the extraocular muscles or anything like that? So we're always going to be limited by what effects something has on the body because we're only measuring a select few variables. For all we know, we could be leading to incredibly important heart rate variability changes. We could have changes in some of the brain structures. We could be having local tissue change. We could be having peripheral tissue change. We could be having immune change. It's just we're not measuring all these variables. So to chalk up something as placebo effect, I also think is throwing the baby out with the bathwater because there's just a lot that we're not measuring to say that things have efficacy versus not. Now, to one thing Bryce said, and this will tie into where I think manual therapy fits, is do I think manual therapy increasing fascial glide is useless or inefficient? When I look at where manual therapy fits with me, and I'm talking about someone who definitely has a bit more of an exercise bias, although since I've started working at Elevate Sports Performance and Healthcare in wonderful Las Vegas, Nevada, check me out if you're in the area. I've been doing a lot more manual. And I think that's just because of the population that I work with now, which is much more fit, active, and sometimes we need these interventions. But I don't think something like trying to improve fascial glide is worthwhile. And the reason why that is because when I'm applying a manual intervention, and this is where I think manual therapy plays a role, you have to have useful test-retest measures to indicate when a manual technique would be effective versus not. When we're talking about fascial glide and we're relying on palpation to see changes, we risk too much of our own bias as a confounding variable with our test-retest. Because if we're relying on palpation, palpation is less effective and less reliable from a data standpoint to use to let us know we're making a positive change versus not. For me, when I'm applying manual techniques, I am looking at changing motion of all of the joints within the body, and that lets me know if a manual intervention is useful or not. When does manual come into the mix for me? Well, I'm glad you asked. I want you to think about this. Let's look at exercise, because we can all agree exercise is probably an important thing, even not from a pain perspective, but if you're not moving, there's a lot of negative health effects that can happen from that. So I think we can all agree that exercise is an important thing. And let's say we want someone to squat well. You might start them off with trying to coach them into a squat and having them do that savagely well. And let's say you have a particular intervention that you start someone with and they just can't get it despite your best coaching efforts. What would you do in that case? Well, chances are you might regress them to something a little bit easier. So maybe you started with an unsupported squat, maybe you go to a supported squat. Let's say that doesn't work. Where do you go there? Maybe you go into something that works on particular components of the squat. So maybe you're doing things that involve deep hip flexion. Perhaps you're doing it in an even more supported position. That could be some type of sitting activity. That could be quadruped. That could be anything. Let's say that doesn't work. Then you might go to something that increases the base of support even further. Maybe that's supine. Maybe that's active assisted range of motion. Maybe that's, I don't know, whatever. Let's say that doesn't work. Then you might work on an even more local thing. Maybe you're working on controlling hip flexion and having them perform things that involve hip flexion in the way you want. Let's say that doesn't work. That step right there is where manual therapy fits in for me. If the person I'm trying to work with cannot attain the position or the orientation that we need them to attain, despite all my best efforts, then I'm going to do manual therapy. And I will use that either as a regression to the nth degree, maybe I try something actively and they just can't get it, so I move them passively. Or the other example at which I will use that is if, let's say I've maxed out this particular quality for the day, maybe I'm teaching them how to stack, but I think from a reduction of symptoms, they might benefit from some type of hip shift activity, or maybe I needed to push air into a particular part of the rib cage. In that situation, I can cheat them into the next tier of progressions by using a manual technique to get them to feel certain things that they need to feel. And of course, I've been talking about that from a little bit of a breathing perspective, but I think you can also use this from other manual interventions. Perhaps maybe someone has no concept of getting the motor qualities that you need to be successful. Well, what is the regression of motor? To me, that's sensory. So maybe you're utilizing different manual techniques to get the client that you're working with to experience things sensorially in the area in question. That could be skin gliding, that could be pain via dry needling, that could be a lot of different things. That could be sensory discrimination. All of these are manual interventions that I think could be quite effective for your supreme clientele when they can't perform the action on their own. And that can be either to regress something that's really challenging, or you take them to the next level by doing a manual technique. That would be one instance. The other instance would be some type of symptom management. You do all of your active stuff, they still experience some symptoms. Maybe you want to do something to alter viscoelastic properties, create some positive neurophysiological effects to increase endogenous opioid and cannabinoid production. So there's a bit more pain relief. That's another place where I think manual therapy is useful. Because if you can get someone feeling good, and I think within this framework, you don't develop dependency on a particular task, then I think it's quite effective and it plays an important role in your interventions. And that's one of the caveats that I give all of my patients is, I'm going to do this for you, but I need you to do these activities so we can either get the changes to stick better or so you don't need me. Because there's going to be a point in time where someone may not be working with me. And that's what I would expect. I would expect all of my patients to have some independence unless they're training with me. And even then, I want them to be able to problem solve through their issues and figure it out. But we can use manual therapy to get them feeling good in the short term or to get them into positions that they might not be able to get into currently. And that's where manual therapy fits in for me. And that's all under the guise of being able to positively change things that I can test that are more reliable than vision or palpation or motion palpation, anything like that. So a lot of my interventions, I'm looking at joint range of motion, testing and retesting that to see if a manual technique elicits favorable changes. Not just the tests that mean something to me, but also that mean something to my patients. So that's where looking at comparable signs of active motions or even the tasks that were painful are really important. To summarize your amazing, sexy question, Bryce, manual therapy has efficacy for a lot of conditions. It's just the evidence is mixed, just like everything in our profession. But Hippo A, it's better than exercise. What you gonna do about it, you manual therapy haters? It, in my eyes, is a regression from a motor skill that the person cannot currently do. And that's where I try to apply manual therapy, or in palliative cases. If someone, you do a bunch of things and there's still some symptoms at play, that's where I think manual therapy is effective. You want to try to apply the least biased testing to help you determine when you should do a particular manual technique versus not. Palpation, not the best testing. Movement, probably a bit better testing. And if you do those things, I think you will be operating within best practice right now. You'll probably get better outcomes, and you ought to be in business. Unbelievable question, Bryce.